Hi everyone, this is Molly Hill. I'm so glad that you are joining me for this first video of my channel, after the introduction of course. I wanted to add this onto the beginning of the speech that you're about to watch because just the first minute or two got cut off, so I wanted to make sure I added this intro for you. It's a speech done at the University of Maryland Eastern Shore, UMES, and it was an amazing experience because it was done with the physical therapy department, the students and some alumni, and I think some physical therapists that were in the area, and other majors, some students from other majors, I believe, may have been in attendance as well. It was just wonderful. There's so much useful information for what it's like for us on a daily basis living with EDS, what it's like in physical therapy, and what a special, unique relationship that is, what it's like going to doctors, what our bodies go through. It's chock full of great information. The interaction with the students was wonderful. I can't wait for you to see the question and answer part and just all of it. So enjoy, and I can't wait to see your comments. Please leave comments and questions. My email is listed on this YouTube channel, mollythepaperzebra@gmail.com. You can certainly send me questions or any inquiries. If anyone that would like to have me do a speech or question answer or talk or anything, please feel free. I would be thrilled to keep spreading the awareness about EDS and what it is like. So thank you so much for tuning in and watching the speech that's about to take place. And UMES, thank you again for having me. It was an amazing experience. And everyone, please help me share this awareness. Share this video with everyone that you possibly can. Share it on Facebook. I'm going to share clips of it on Instagram here and there. Definitely on YouTube. Any way that you can. Send it to people through email. Any way that you can share it. We need to get the word out about what this is really like, so we can have compassion, understanding, diagnosis. That is the most important thing, diagnosis, a lot faster, a lot earlier for people, so they can get the treatment that they deserve, period. They can get the treatment they deserve. All right, take care everybody, gentle hugs, bye-bye.
Reached out and actually took me up on my offer to talk. I do this all the time, and thank you for posting that poll there, because that almost brings me to tears just seeing how many of you have heard of it. You know, that's our biggest challenge, is that so many people have not heard of this. In the medical field, doctors, PTs, nurses, there are so many that just have not heard of it. Or they may have heard of it but don't know anything about it, or they just think it's the stretchy skin, or they still think it doesn't cause pain, or what have you. So knowing that you've just heard of it and it's the start of the conversation is wonderful. So that's great. So what happened with Elizabeth actually is what I do a lot. When I run into people, her younger brother is my son's best friend from like elementary school, and they've gone to school together for years, and we ran into each other at the grocery store, and I told her, if you ever need a subject for a paper or anything. So when she contacted me, that's what I thought this was, is she wanted me to talk to me for a paper or something. And I'm so glad this, because the more people I can talk to, and that you really get what this is like, and that's what I'm going to talk about, is what this EDS life is really like. I know on the invite that Dr. Gill, and Dr. Gill, thank you so much for having me. I'm thrilled to be here. It's been a pleasure talking to you, today, and through all of our emails and correspondence. So there's a link at the bottom of that invite that has a great video from the Ehlers-Danlos Society that has a ton of clinical information, and it's very easy to understand. It really is. It's not the most exciting thing, but it's great for information. It really is wonderful. So please look at that if you haven't already, please watch that for information. I'm going to do it more from our side, but I also want to touch at the end, I really want to make sure I save time on the importance of that relationship between a physical therapist and an EDSer, because it is a very different relationship than you'll have with any other patient. And we spend more time with our physical therapists than we do with any other clinician, any other healthcare provider. You know, I'm 45. I can't believe I'm saying that to you. I'm 45, and I have been going to physical therapy since I was 15. So I've been doing this a long time. So I've been in and out of physical therapy for 30 years. And I will be in and out of physical therapy for the rest of my life for whatever, whether it's post-surgery or whether it's for my neck is stuck or my vertebrae needs to be straightened out, whatever it is, I will be going for the rest of my life. And that's where a lot of us are in that situation. So, you know, when I ran into Elizabeth, you know, like what happened with offering that to her, I do that when I'm in physical therapy. Whenever there are student PTs there, I give them my wallet card. There's a printable wallet card on the EDS website that has a great list of all the symptoms and signs of EDS. And I give them my card and I tell them to go make a copy of it and read it. I say, now go ask your professors if they have heard of this. Go ask them questions. And I probably should, excuse me, Dr. Gill, I probably shouldn't ask them that, but I said, I bet you'll know more than your professors do when you go ask them about this. And none of them have, well, I don't know. I said, they never come back and tell me that they've done it and you know, stump their teachers or anything. But I hope they start the conversation. I hope they get talking about it. So I'm thrilled that Elizabeth took me up on the offer. All right, so about getting the word out. I will talk about it to anybody. I've literally talked to cashiers at Walmart. I will talk to anybody that asks me about things when I have ring splints on my fingers, when I have my rollator walker and I changed lights on that with Christmas lights or whatever the season or holiday. I will bring attention to it, because if it means somebody says, hey, cool lights, or hey, I like your ring splints, that's cool, or that's cool jewelry, and I'll say, oh, it's not jewelry, let me tell you about it. You know, even if someone just hears the term Ehlers-Danlos Syndrome, it gets the word out. If I get to tell somebody about what it is, that's one more person that can recognize the signs of it a little bit, and they might be able to see it in someone that they know and love and care about. Or even themselves. You know, we don't want anyone diagnosing themselves, but it helps a lot if someone can say, hey, I'm noticing all these symptoms in myself, and they take that information with them to their doctors, and I'm going to talk about that in a second too. All right, so if you see me keep looking down, I apologize. I go off on a lot of tangents, so I have to make sure I stay on task here. I do have some notes. Okay, so let's talk about what is EDS anyway. So in case you haven't watched the video, I know you talked about it a little bit in class, but what is it? So, all right, it's a connective tissue disorder, which affects your collagen. What is collagen? It's the glue of your body. It's what holds you all together, right? It affects the protein. So as of right now, they just added a 14th type of EDS to the categories. So there's 14 different types of EDS. The most common is the hypermobility type. There's also classical type. Classical involves more of the skin fragility and stretchiness. But there are so many overlapping symptoms from type to type. It's really hard sometimes to diagnose someone. Vascular is the most dangerous, because literally that your vascular system, an aortic dissection, something can happen where your organs can literally rupture, and their life expectancy is longer now, but it still is not as long as everybody, as long as we love it to be. Hypermobility is, I don't like, oh gosh, I just banged the counter, my dog's barking now, sorry. I don't like that people say it this way. They say that, you know, hypermobility is the mildest type, that it's not dangerous. A lot of people say that, and while it is the mildest type, that's just simply not true that it can't be dangerous. I have a family member, my biological mother, and I'll get into that too. My biological mother has, and a friend of mine actually that lives near me that has EDS, they both have very laxed esophaguses, and they choke on food. You know, there's people that have to have feeding tubes. There are people that, you know, their muscles in their necks get so tight that it can close off their airway. There's people that their digestive system, literally peristalsis, stops because that connective tissue cannot push substances through their system. it can be incredibly dangerous. And when you do have those overlap, and it affects the heart, connective tissues in your heart. It's in everything, bones, muscles, tendons, everything in your body. Every cell of your body has collagen. So it can affect every single system in your body. That does not mean that it will, but it means that it can. And I say that because there are a lot of people that as soon as they hear that they're diagnosed with EDS, and any condition, they go onto the message boards on Facebook, on Instagram, on whatever social media forum, and they start reading what, they go into the groups and they start reading what people have and what they're going through. And they think, oh my gosh, I have EDS. That means I have to go get a wheelchair now. Oh my gosh, I just got diagnosed with EDS. That means I have to get every splint, every brace out there. Oh my gosh, I have EDS. I have to go get a walker now. I have to go get a handicap thing for my car now. No, not at all. And that stuff, see, I want to talk about so much stuff, and these are things that I want to do speeches about everywhere, about all these different topics, because it's so important for our lives that we understand how to live this chronic condition life. So with that, so what I said with that it can affect every system in the body. It does not mean that it will, but it can, which is what makes it so hard to diagnose. So EDS, they used to think it's still considered a rare condition. I don't like to say disease. It's not a disease in that it's a foreign body came into you, or it's not a sickness like that. We call ourselves, but it's not like we have a virus or something like that. But it's syndrome condition. So it's not rare, it's rarely diagnosed. So, or misdiagnosed for lupus, for rheumatoid arthritis, for it's all in their head, they're med seeking, things like that. That's what people hear a lot. They're hypochondriacs, they want attention. That's another thing we'll tackle. But so people used to think that it affected about 1 in 15,000, then it was about 1 in 10,000. Now they're saying about maybe 1 in 5,000. But it's probably about, I've seen many sites that have about 1 in 500 probably. So again, it's so hard because it's a spectrum disorder. Just like we're so familiar with autism being a spectrum disorder. And I have my oldest son who is a freshman at UMES in the agriculture program. He has Asperger's syndrome, very high functioning. He's at this end, and then there's people that are all the way at this end of the spectrum that are very serious. EDS is no different. You have people that have it and never even know that they do. It doesn't affect them much. It doesn't cause them much pain. They might think, oh, it's that trick knee from a football injury. Oh, I just hurt my back, skiing the other day. Or it doesn't affect their life on an everyday basis. And that's the key thing. You're going to hear me say that phrase a lot, everyday basis, every day in your everyday life. That is a huge key factor. And any of you that are physical therapists now, that is something that really, really, really needs to be in your mind, is that how much certain things, certain ailments, certain what your patients tell you about whether something needs to go to the next level, whether they need to go to a specialist or not, how much this is affecting your everyday life. Decision whether to have surgery or not. How much is this affecting your everyday life? And you'll know, we know when it's time to have surgery. You can't, when I had my 3rd hip surgery, I knew I could not go another day. Forget it. I was going to have that surgery today if I could. It was going to happen. So with it being so hard to diagnose, it's not just in the fact that it's a spectrum disorder. So within the people that have it, okay, say we know now the people that do have it, okay, we know this group of people have it. But within this group of people, it varies so much from person to person to person to person to person. And not only from all these people, but within one person, within me, it can vary within me from week to week, day to day, sometimes hour to hour, and even literally minute to minute. There are times when, I could be walking yesterday, take my dog for a walk with my family, and maybe, play in my craft room, or, things like that. Maybe go shopping or something one day. The next day, 3 days, I can't walk because I can't put that weight on my legs, my knees, my ankles. Can't do it. Or my fatigue is so bad that I literally can't lift my arms up, or support my head. It can change that fast. I've had episodes where it kind of falls under the dysautonomia umbrella, which is dysfunction of your autonomic systems, things that your body automatically takes care of for you. So POTS falls under that, regulating your body temperature. Brain fog, really, oh gosh, that really happens a lot for us. But sleep issues, I have this dizziness thing. It doesn't really fall into a category that I can find, but it's where I feel like I'm going to fall asleep. But I can't stop it. We've literally been at a party at my husband's parents' house, and I said, you got to put me somewhere because I'm going down. And he's had to put me in a recliner in the middle of a party, and I was out, and that was it. It doesn't happen that often, but it happens. And I call it my brain tingles, my head tingles, and it's just this feeling that I get. I have a lot of ways of explaining different things. I see pain. I'm a very visual person, and I see my pain in different ways, and I explain them different. I have my neon sign pain, and I have my rusty metal clamp, vice clamp pain on my pelvis. I have all these different ways that I explain different types of pain. So, and you'll get used to, if your patients, you get really used to them, and you talk a lot. You have to talk a lot with your patients and get used to the way they word things, because everyone will explain things a little bit differently. They'll have little colloquialisms. They'll have little ways that they say things. Write them down, because they know what they're trying to say. It's just how they might see it. Or it's so different than what everyone else experiences that that's the only way they know how to describe it. And sometimes it is really hard when you're having bone pain, nerve pain, muscle pain, all at the same time. And you can't distinguish between one or the other. That's another thing that makes it so hard to diagnose, is that you're experiencing all these things at one time, sometimes. So you walk into a doctor's office and you say, okay, I'm having heart palpitations, headaches every day. I have headaches every day, literally. Every morning I wake up, it's been for the last 5 years, maybe. I've woken up every single morning, 365 days out of the year, with migraine headache. My husband brings me ice packs. He brings them for my lower back and my hips, and he brings one for I have a really cool head wrap now that I put on every morning to help my headaches go away. I have medicine for it and stuff like that. I've tried injections. I've tried all this stuff. It just is what it is sometimes. So, you go in with, I have heart palpitations, I have headaches, I have joint pain, I have IBS, I have dizziness, brain fog, I have all these things. And a lot of times, doctors will say, not one person can have all these things going on at one time. I'm sorry, you're searching for something. You're searching for attention, you're faking, I don't know what you're doing. And I'm saying that because I've had many people tell me that. You see that a lot when people share their stories, and that happens. I have, again, my biological mother went into a doctor, went to show him, handed him her MRI, and she went to explain something to him, and he put his hand up and said, I only look at pictures. It took everything. If I could have walked, and it was a day I could not walk, if I could have walked that day, I would have gotten in my little car and I would have gone right over there, because one, I don't hold my tongue very well, and two, it is the most inconsiderate thing. We are human beings that go through a lot, and we take on a lot, and we try to hide it a lot. We are the best actresses on the planet, I tell you. We really are. Well, a lot of us are. Okay, so that's the big thing. So it's so hard to diagnose with the numbers. It's hard to tell who really has it, the spectrum. We can have so many things wrong at one time. have so many things that, it's hard for us to differentiate what's going on at one time. It really is, it's hard. That's why you, on average, can take anywhere from, 2 to 10 years for someone to get diagnosed with EDS. It really can. I got lucky. And you know what, I should have said this right away, because for people that watch this down the road, I have to say that I'm very fortunate, and I know I am. I have an amazing support system of family and friends and healthcare team and everything. And I've never been ignored about it. Everyone's always believed me, but I've been able to pop my joints out in people's hands. I can prove what my body does. That's my biggest issues are my joints. Where somebody else's, their biggest issues might be their GI system. My biggest issue are my joints and my pain. So I can prove that. I can pop my hip out in your hand right now. I can bend my joints in ways you're not supposed to. If my shoulders weren't screwed in place, I could easily, do a bunch of party tricks with them. So that's why I've never been sent away. I've never been sent away or denied help in an emergency room. So I'm very fortunate. I've never gotten weird looks using my handicap tag. Even if whether I'm using my walker or not. So I'm very fortunate. There's a lot of people out there that are not. They don't have that support system. They don't have family members at home that believe them. They just don't. They haven't found the right doctor yet that can put all the pieces together. They might be in doctor's appointments 2-3 times a week, every other week, for doing this for years, trying to get answers. You might be the one that puts it together. That makes me emotional. What if you're the one that puts it together? What if you're the one that just by taking a few minutes to look at a symptoms list, to watch some videos of people that are going through this, of looking at some research going on, what if just by doing those things that take a few minutes, what if you're the one that can put those puzzle pieces together for somebody? You will change their life for the better. And no, there's no cure for EDS. It's hereditary. You have a 50% chance of passing it on to every child that you have. So the fact that they're working on cure, they're working on it. Research is definitely going on. But with the fact that it's part of our DNA, people ask me a lot, can't you just get, collagen injections? No, because I would just make more faulty collagen. It's my collagen that's faulty. So it doesn't quite work like that. They're working on it. So it's the difference between treating the people that you come into, whether it's a patient of yours, someone you meet at a party, someone you meet, at school, whatever it is, having the common courtesy, even if you want to call it just common courtesy, to listen to someone and maybe put some of the pieces together for them to change their life. Okay. Oh, jeez, I'm sorry. Oh my gosh. Oh, I scared the Jesus out of me. All right. So I'm going to tell you, this is supposed to be about living with EDS. So here's my story a bit. And, I'll tell it as quickly as I can. I want to make sure that I do talk about the physical therapy relationship and have time for questions. I really want to make sure that we get that. So, and hearing my story, you'll also get a lot of more facts about this too. So, all right. So like I said, it's hereditary. You're born with it. Some people you can tell the signs right away. You can tell by babies' hips. You can tell, how they're moving right away. Babies, little kids are so flexible anyway. Usually they won't try to diagnose children before 5 years old, approximately. So unless it's severe, unless it really stands out and you can tell. Usually you try to hold off until they become a little more sturdy on their own. My childhood, nothing really stood out except when you get diagnosed, you can look back and say, oh yeah, that makes a lot of sense. I had a lot of what my dad would say, oh, they're just growing pains. I had a lot of pains in my legs, my lower legs, especially my shins would cramp. Excuse me, my shins, my knees would cramp a lot. Headaches. I had headaches as a kid to where my dad would kind of lay back in bed and I would lean into him and he would even do this like meditative visual thing to try to just get me to calm down and relax until the headaches would go away or I could fall asleep or something. So I've always dealt with headaches. And a lot of it has to do with, when you have laxity in your joints and your ligaments and tendons and they're not holding your joints in place the way they're supposed to, your muscles take over. They're trying to do the job that your ligaments aren't doing. Okay. So like, for example, when my shoulders were so loose, I was a swimmer. I was a competitive swimmer for a long time. And a lot of times you hear swimming's the best thing you can do. Well, it's not when you're swimming Division I and swimming, I was in the pool more hours than I was in the classroom, and that's not the best thing to do. But my shoulders were so loose that all the muscles around my shoulders, my delts, my lats, my neck, oh my gosh, my neck were so tight. Everything was so tight that I even have this one knot that I've had since I was, I think, like 16 years old. I even named it at one time, but I can't remember what I named it now. But they are doing the work for you, so you can spasm. I have to try not to shiver. When it's wintertime, I have to try not to shiver because my sternocleidomastoid will literally go into Charlie horse spasm. So I really have to try to avoid shivering at all costs. It's not a pretty sight. So, okay, so, and speaking of cold, I have a comorbidity thing with EDS. There's a lot of other things that go hand in hand with EDS that a lot of people have, like POTS and things like that. I have Raynaud's syndrome, which is really poor circulations in the extremities, like hands, feet, fingers, your nose, ears, where you can get painfully cold. I used to get so cold and hurt them. I remember my father just, breathing onto my hands and all this stuff, and it would hurt so bad, and it would take hours and hours, for it seemed anyway, as a child, for them to warm back up and not be painfully cold anymore. And I still have that. Not as bad as when I was a child, though, thank goodness. But so that's mostly, my childhood, that's what was going on. And then my teen years, when I was 14, with my swimming, as I got serious into swimming and started swimming instead of summer, I went to year-round. I started running also, and I was a breaststroker, and, that whip kick, my knees started really hurting. And by 15, they were so bad that I started going to orthopedic surgeons. Now, again, I was lucky. My dad worked in orthopedics. He sold joints and all that stuff and helped the doctors in surgeries, and I had braces and bones all around my house and all that stuff on the dining room table. And so I got to try out a lot of things. But, so my dad took me around to several different orthopedics and orthopedic surgeons, and I think it was the fourth one that finally said, oh, it's breaststroker's knees. I can't say the Austrian slaughters, I think it is, something like that. Because the muscles on the outside of the knee get so much more developed on the inside that it literally pushed my kneecap off to the side. And so by the time I was 16, I had a surgeon literally throw a full leg cast on my left leg because I wouldn't stop. It didn't matter if I was, dislocating and all that stuff. And I just switched to a public school, was going to homecoming, and he put a cast on my leg. I had a temper tantrum like a 3-year-old, literally. It took like 3 nurses to talk me into getting this thing. It was not my finest moment. So, so then, my hips started getting sore. I had injections in my hips, I think by the time I was like 18. But by senior year of high school, I started getting, I would go to stretch before practice, and I would lean my arms up on the wall and stretch, and I would start to hear a pop, and I would stretch, and oh my God, it felt so good. Just like when people crack their knuckles, and you hear them go crack, 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 and they just, they love it. I can't crack my finger knuckles. oh, my shoulders, I could pop, and it was so loud. It was so good and satisfying, especially when you creep people out and they're like, ugh, disgusted by it. It was so satisfying, and for some reason. And it didn't really occur to me that I was doing something really bad, but because it just felt good and it helped me loosen up to swim. But by the time college rolled around, and that had taken me to a chiropractor here and there to help with the muscles in my back because they were really tight and stuff. Didn't really help. Chiropractic care is not the best for EDS people at all, really at all. If there are chiropractic people out there that really know what they're doing with the EDS people, I'm thrilled, because a lot of times we hear not to go down that route. But I wish I felt safer doing it, because it could really help a lot of issues. So by the time I was when I went to UMBC, University of Maryland, Baltimore County, so in the same system, and Division I, very, very excited about that. And like I said, I was in the pool more than I was in the classroom. And by sophomore year, Christmas of sophomore year, I had my first reconstruction. I would go to physical therapy before practice, or the athletic trainer room, before practice, after practice. Oh, I forgot something. Back up. Knee. I went to physical therapy for my knees. And the biggest thing that I remember, I went to Towson Sports. I'm from Towson. I went to Towson Sports Medicine for a few years, off and on. And they kept saying to me, they said, we don't understand. The more you do, the worse you get. And now, of course, as soon as I got diagnosed, it's like, oh, the bell goes off, of course. But they said they had me wear my bathing suit one day, and they took me in a room. They're taking measurements, and they're checking my leg length discrepancy. They're looking at all this stuff, because they were like, we don't get it. We don't understand. They're so frustrated with me, because they had me doing like biofeedback on the wall, and I was doing like speed skating moves, and I was doing all this stuff. And I was strong from swimming and all that. So thank goodness my muscles were strong to help hurt my joints. But who knows how much damage I really added on at that point. So I love my physical therapist. Oh my gosh, the physical therapist that helped me after my shoulder surgeries, oh, we became so close. I even house sitted for her. So don't underestimate the relationships that you form with us EDSers, because it's, like I said, it's such a different relationship. You have to get to know us on a whole different level. And we're very unique. We're very special. I promise you'll find that out. Sophomore year, I had my left shoulder reconstructed. We started scoping it. I wanted to clean it out, see what was going on in there. He said, if I have to open, I'll open. So I remember waking up and said, I asked the nurse, I was like, what did they do? And she said, they opened it. And I just burst out crying. And he told my parents that as soon as he cut my skin open, my shoulder fell out. And he had to hold my arm in, like while I was doing it. I was so small, I didn't fit on the table right. Yeah, it was a mess. Labrum tears, bursa sac was so full of stuff, and rotator cuff, everything. It was just a mess. So what they did is they drilled 3 holes in my bone, shoved my ligaments in there, and screwed them down tight. And I was not supposed to do physical therapy for a little while. Let the scar tissue build up. Try to keep it tight for a little while, and it's held. I won't do it. I can separate it, and it's gotten looser. But it's been a long time, and I was 94. And so I haven't had to have it done again. So that's great. Knock on something. A year later, almost to the day, I had my right shoulder reconstructed. That's when my surgeon put it together. That's another area that I got really lucky, because that's when I got diagnosed. Now, I hate this next sentence that I'm going to say with a passion. This was before the internet. This was before Google. Makes me feel very old saying this. I hate it. So he said, you know, something else is going on here besides swimming. If in 1 year of just doing PT for this shoulder, you've measurably stretched out more for this shoulder. My dad took me for a second opinion because he felt he knew every orthopedic, you know, and so he took me to another one. Just for a second opinion. He had me lay on the table. I dropped my arm back. The ball of my joint came out my armpit, and I had over 150 degrees external rotation. And he said, "Yep, I second it." And that was it. I was in that office literally 5 minutes, if that. And so I had this one done too. So yes, I don't like that pre-internet comment, but here's why it's significant. So my surgeon said to me, this is not just from swimming, because I can pop my hips out, you know, my ankles are loose, my knees are loose, my shoulders stretch out the way they do. And at that point, I had already had 16 teeth pulled. I just had my 17th teeth pulled last month, actually. So that's a lot of teeth. That's one of the symptoms of EDS is overcrowding, high palate, overcrowding of teeth, narrow jaw. That's a lot of teeth. You know, it's too many things. And that one I didn't know yet until much later, but that's a really cool fact. So he said, you have Ehlers-Danlos Syndrome. And the reason I know it is because my wife has it. So I feel horrible that she has it, but thank goodness, because I got so lucky. So with the onset of having symptoms, like real symptoms, and knowing something was up, kind of off and up, and to, having these surgeries, and, that was about 5 years. I wasn't looking for a diagnosis. I didn't know there was something to diagnose. But now I had this diagnosis. But what could I do with it? Nothing. There was nothing to do with it. There weren't any, there wasn't the internet. I couldn't talk to anybody about it. The only thing that I was told was, monitor your heart and be careful. Okay, that wasn't scary at all. So I know I'm watching the time. So basically it got, I just avoided things that, I didn't go back to swimming. I coached for years, which I loved. So most of my 20s, I just avoided what hurt. I was careful, did what I could. If I could work out, walk, do things, I did what I could. I was a teacher for half my life. Then I got pregnant. So we started our family. Now, I'm going to say this really quickly because I see the clock, but it is very significant. I've been pregnant 5 times. My first pregnancy was an ectopic pregnancy. Left tube removed, rushed to the emergency room, left tube removed. Second pregnancy was my son Cameron, who is the freshman at UMES. He was 2 months early. And arm was coming out first, so he was also an emergency C-section. But my cervix wouldn't stay closed, and that triggered contractions. But they held it off for a while in the hospital. As soon as they stopped the drugs, that was it. He was coming. Third pregnancy was our son Brady. I went into labor at 18 weeks. At my 18-week sonogram, they put this up on the wall. My cervix opened. His feet went in. Feet came out. My cervix closed back up. They called people into the room to watch this. It was horrible. They said, we're going to sew your cervix up right now. I was there, ready to go. IV started, and I was like, I'm having contractions. So couldn't do it. They just sent me home on bed rest with medicine. And a couple more, week 20, I went to another hospital, and they said, well, you're 3 centimeters. He's either going to be born today, or we can try to stop it. So I wanted to try to stop it. And we were just trying to make it to 24 weeks, because that was as early as they would try to save a baby then. And got to 22 and a half, and my placenta abrupted, tore away from the wall. So he was born. And then we were done. that was it. We had our miracle. Cameron's a miracle. If you meet him, you'll know that. And then and after we went through all that, my surgeon said, "Oh, you have EDS? Oh, well, that might have something to do with it." So we're like, "Okay, well, so if you get pregnant again, then we'll do this." I was like, "No, we're done." But the following year, I got pregnant. Didn't mean to. I didn't think I could get pregnant without fertility drugs, but I did. And then at 6 weeks, I had a miscarriage. And you have baby on the mind, so I said, well, give it one more shot. Got it, one more try in me. And 2 weeks later, I had a positive pregnancy test. And his name is Matthew. He's 13, and he's perfect. Made it to 35 weeks with cervix-zone shut, progesterone injections to keep pregnancy off. Went into labor at 28 weeks. Made it to 35, and he was coming, so I had to rush to the hospital to cut that stitch so he didn't break through it with his head. Sorry if this is too much detail, but it's just the way it is. You're in the medical profession, so you're in healthcare. Yeah, so when women say, "Oh, I was in labor for 24 hours," I just want to say, shut up. I was in labor for 6 weeks. So I'm just kidding. Labor is labor. And then so he's perfect, and then I was fixed. That was it. We're totally. So that did a nice number on my hips, even more than they were already messed up. So I've had 3 surgeries on my hips. I had on my right hip, labrum tear. They couldn't get my capsule to close. The stitches, when they were trying to close my capsule, it just kept tearing right through. So we left my capsule open and closed me up, and hoped scar tissue would just take care of it. A year later, I tore again. It took me another year to find a doctor that would physically touch me. When I finally did find that doctor, it wasn't even a month before he got me in, and he did he put a cadaver labrum in and got my capsule to close, and it was great. Then, so it was 2014, 2016, now 2018, I had hip surgery again. And because my hip flexor was so awful, I couldn't bend down to put my own socks and shoes on. And that's kind of stuff that there's so much. But this is the stuff we go through, is my point. I had to stop teaching because my neck, I was on my feet all the time. I couldn't hold the books anymore. My neck would spasm up, and I couldn't turn my head for 3 weeks. Richard Horsey, the brilliant, brilliant, brilliant Richard Horsey, physical therapist. He is a voodoo master. Dr. Gill taught him, so I'm not surprised at all. He is amazing. He is phenomenal. I see 2 physical therapists. Bill Bales, who is the owner of Coastal Physical Therapist. I go to him post surgery usually. Well, no, I figured that out. I always go to him post surgery, and I go to Richard for everything else. When I am stuck, when I can't inflate my lungs all the way because I was cleaning my shower and my muscles got so tight that I can't inflate my lungs and I can't breathe, and he has to work on the muscles so I can take a deep breath. Those are the kinds of things that we go through. Those are the kind of things that we deal with that you would never think of. You never think people go through those kind of things, but that's what we deal with. So I have so many more things I want to share, but I also want to make sure that you guys get some time to ask questions. One thing I have to say about the relationship with our physical therapist: time scheduling. However you schedule your time with your regular patients, if you know you're having a patient coming in, you need more time, because just the conversations with them, the initial appointment, then when you're getting to know them, you're doing measurements, and you need more time. You need to have the time to see what the limitations are. That has got to be the key word, is limits. Limits, limits, limits. There has to be okay, we can stretch you this far, but no further than, X degrees. I can stretch your hamstrings to this, but no further. We can do this, but no further. You've got to work on that, find that, because it is a very fine line between what is beneficial and what makes us stretch out that much faster. So, and it's up to the both of you, those things out together. It is okay to say, I don't know everything about this, but you always need to follow that up with, but I am willing to find out. The best thing that Bill Bales ever did was, he is a research junkie. If you know him, you know this. If you don't, he is, and you have anything rare at all, he is a research junkie. He loves it, loves it. And he will research anything. He'll do anything to find an answer for you and to try things. He came up with this whole SI joint stability thing for me with kinesio tape to try to help hold my SI joint in place, and my whole pelvis was taped up and I had adhesive everywhere, but it helped, it worked. Just try something to help me. You know, it's a give and take relationship. It's like, let's try this, let's try this. Did it help? And he notebook on, you know, what helped and what didn't, what worked, what didn't. Richard would do the most simple, I wouldn't even be able to detect that he was doing anything. It's such a light touch, the littlest things, but oh my gosh, it helped immensely. And he listened, and he was one-on-one. You're in a room with just him for an hour, and he just, that's it. It wasn't like a wall full of beds where you're just with him, you know, with a room full of people, you're just with him. And not that that's always possible, but anytime you can, any way you can get more time with that one-on-one patient, or with that patient, it is crucial when you have an EDS patient in front of you. Okay, I want to see if there's questions.
So Molly,
Yeah.
I just want, could you briefly describe POTS briefly, and then just reiterate briefly about the fatigue?
Absolutely. POTS, it's under that umbrella of dysautonomia. It's a comorbidity condition that goes along with a lot of things that go along with people with EDS. So postural, oh gosh, tachycardia syndrome. What's the O? It's
Orthostatic.
orthostatic. Thank you. I was like, I can see the word orthostatic. Yeah. Yes, tachycardia syndrome. So it's a drop in blood pressure anytime you change positions. So if someone, say someone is standing and they go to sitting or laying down, or they're laying down, it's very hard, or laying down and getting up. Their vessels have a really hard time squeezing, getting that pressure back up to get the blood flowing to where it needs to go to get the blood pressure through the heart, get it where it needs to go. So the blood pressure can either skyrocket or it can drop. There's different types. I know there's different types, but I'm certainly
That's okay. You don't have to do that.
Yeah, but that's what it has to do with. Changing positions changes the heart rate drastically.
Yeah. So just again reiterate the fatigue that patients experience.
Yeah. Yes. Now it can get to where you actually can get diagnosed with chronic fatigue syndrome, or it's where you just have chronic fatigue. Now, chronic fatigue is not tired. It's not being tired. And when people say, oh, I get tired too, oh my God, no, that falls under the category of things not to say. No, it's not tired. It's not just sleep. It is where you literally feel like your cells are depleted, and when you can't talk. There have been times when I've not been able to complete sentences to my own children. You know, where you can't lift limbs, when you can't, you know, it is a depletion of energy. It's not just tired. And where you know if you get a decent night's sleep, get a good meal, you know you'll be okay again tomorrow. It's not that same kind of tired. It is where it takes, and it can take it from multiple systems of your body. So it's not just your head, it's not just your body, it's not just, it's full on.
Okay, so how about questions from the group? If you'd like to type it in the chat, that's fine, or you can raise your hand and then we'll call on you to turn on your microphone and ask your question. Either way. Or if you'd like to share an experience that you might have had with a patient with EDS. Yes, EJ, go ahead.
Hi, I'm so glad that you got to do this, and I'm very excited to be here and listen to you. I was wondering, a question. So, how often do you experience symptoms, and do you have a specific physical therapy example of like what not to do?
Oh, yes, I do. Okay. So, okay, what was your first one, Elizabeth? You said
How often do you experience your symptoms?
good question. So, okay, oh, yes, I'm so glad you asked that because that is a huge thing everyone in healthcare needs to know, and family members and friends. Huge thing everyone needs to know. Okay, this is another thing that with EDS that falls under the what we wish people understood. So, symptoms. There are times when I know if I went shopping, if I cleaned, and my hips hurt the next day or my back hurts, I know it's because I did that the day before. I can pinpoint to why that happened. Then there are other times when there is no rhyme or reason for why I feel the way that I feel. Like, for example, I just spent the last 5 or 6 days in bed with pain that my breakthrough pain meds didn't touch, which I haven't had that in years. There's times when fatigue can hit and I don't know why. I didn't do anything out of the ordinary. There's times when like I might have weather, definitely. The whole thing about weather, yes, is definitely true. I know my family doesn't even ask me anymore or watch the news or anything about the weather. They just ask me because I know with my knees and ankles that it's just a very specific way that barometric pressure hits the fluid in your joints, and I know when it's gonna, rain or something. So, but yeah, so there's no definite pattern. I can say usually it's activity for me because I have a hypermobility type. It's mostly my joints. So it's mostly because of activity, but it doesn't have to be. It can be any reason. Very good question. And I'm sorry, the other one, Elizabeth, I'm sorry.
A specific example of what not to do,
Yes.
like as a physical therapist.
Okay. You cannot assume that your EDS patient, if they just had an ACL repair, is not, say you have a 30-year-old woman that just had an ACL repair. They are not like the 30-year-old woman that you just had last week that had an ACL repair. They cannot do the same prescription. They will not be in there for the same amount of weeks. You cannot just say, here are your exercises, bye, and walk away. You cannot do that. You might get to a point where she's far enough along and she knows her routine, she knows her, she's feeling good that day, and you can say, are you okay to do these 3 exercises on your own for a few minutes? And she says yes, and you can go see another patient. But you always make sure first, always, never assume that you can just give the exercises and walk away. Your EDS patient, even if it's a mild case, you can never assume an EDSer is like a regular, normal patient. Never. And I've had a very bad, I had a root canal 2 years ago. And my jaw, I don't know if you can see it from here.
Oh. Mm-hmm.
My jaw dislocates very easily. Root canal, your mouth is open for a very long time. C2 got very messed up because of just having my head back like that and jaw open and I had to go to physical therapy because of having a root canal because of my neck. Now I told you my 2 physical therapists that I love and always go to. Well, someone told me about a physical therapist that, and I have to be very, very careful. Someone told me about a physical therapist that had something in common with me that I should go to. And so I agreed. And it was awful. This person did not know, but did things like that. There are very few rules with EDS. There are very few things always about with EDS, except that, you know, always or you know, never, or like, but a blanket statement that you can make with people with EDS is that everyone is different. You can say that. You can also say that we're all stubborn. We're all stubborn, and we're great actresses and actors. And because we don't want everyone to all the time. We don't want that at all. We want to live as normal life as possible. That's actually a lot how we hurt ourselves a lot, is because we try to pretend that we're not in pain. We try to pretend like we can do what everyone else can do, and then we hurt ourselves. So, yeah, so I got a lot more hurt than I just did from my root canal. And I had to go to Richard for a month to fix my neck from that experience.
Oh.
And it was okay. I got it. I'm not gonna say anymore because I don't want. I just have to be careful with what I say.
Well, Robin has a question.
Oh, Robin, go for it.
Robin, go ahead.
Can you hear me?
Yes.
Yes.
So I just want to start by saying thank you for sharing your story. I'm just recently graduated, and in my last affiliation, I actually had the opportunity to treat 2 patients with EDS, one being, I think she was in her early 40s, and then one girl who was recently diagnosed at like 14 or 15.
Okay.
And she was actually in the process of getting a DMO suit. It's from overseas. It's just like it offers compression to help, I guess, with like proprioceptive feedback, which was really an awesome opportunity to see. But I can totally relate to them using their own terms and how they explain certain things, and that was very relatable when you said that. So
good. Congratulations, first of all. That's very exciting. On your graduation. Yeah, I have not seen one of those suits. So you're moving up in the modern times. Yeah, that's fantastic. No, that's wonderful. That's great that you're getting that hands-on experience. That you're getting patients with this. That's wonderful.
Yeah, I think it's a lot more common than, like you were saying, than really what's diagnosed. So just keeping an eye out and being aware of everything, like you said, I think is key.
Yes, definitely. I have so much more I want to talk about, so I hope we can do this again, soon, and we can share a little bit more, or just even have a, question and answer session or something. I did give Dr. Gill my email where anyone's allowed to write me and ask me anything, and we can certainly communicate that way as well.
Melissa has a question, and she typed it in the chat. Is anxiety/depression common, especially in kids with EDS? What's the best approach for management? I asked because the anxiety is more likely due to the EDS, correct?
Yeah. Oh, I'm so glad you asked that, Melissa, because that's something I wanted to get to and didn't. Okay, here, and I actually have a note on it right here, because, so when I had to, I'm just using this as an example. When I had to stop teaching, it hit me, actually, it's, well, not necessarily when I had to stop teaching, but I tried for another year and a half to try treatments, other, doctors, treatments, what other jobs could I possibly do before getting disability? I wanted to work. I wanted to try anything I possibly could before that as a last resort, and in that time, and I didn't realize it so much in the time, but afterwards, you realize how much of your life you have to actually mourn that old life. EDS took everything from me, and I'm not saying this to be dramatic. It literally did. It took my sport, which was my passion. I swam and coached my whole life up to that point. My profession, I went to school, got my degree in, and I taught from the time I was 16 to the time I was 34. Took that away from me. I lost children because of EDS. It affects us financially, big time. It affects your marriage. It affects the relationships. I was a very social person, and I barely went out. There was a point in time, a year, I couldn't drive for the most part because of my hip. You literally have to mourn. You go through the stages, of a death. You have to mourn that old life, literally. And that's something I really want to do with these speeches too. That's something, a whole other thing I want to do as well, helping people with EDS or any chronic condition. That's a whole other thing I want to help people with. Because like I said, I've been doing this a long time, and I want to help people with this. It is a big issue because, yes, everything that you've done in your life, all of a sudden you can't, not all of a sudden, it's a degenerative disease, just like aging. As you age, your body gets weaker and tighter and, older, and all these things happen, and injuries and stuff. We're just on hyperdrive. It just happens a lot faster and a lot more severe. So it's, it's finding that balance. And this is what I'm very passionate about and to try to help a lot of people with, is finding that balance between, yes, we have this condition, but and we have to respect it. We have to stay on top of research. We have to go to the doctors. We have to take care of ourselves. We have to, admit we have it so we don't do stupid things to ourselves. But it can't be our life. It cannot be everything. We have to make sure that, and this is a slogan a motto that I live by. I actually want to make t-shirts with it that says, do what you can do when you can do it. And I have to live by that every single day, because there are days when I can't get up and do stuff. So, and that's okay. It's all right. If you have days when you have to stay in bed and read or watch TV or watch movies, I actually have a whole thing about TV therapy. It's brilliant, I'm telling you. And it's all about distraction. Sometimes it's the only thing that works. And then, but if I can go, I sew and I craft and I make cards and if I can do that, if I can do it for 20 minutes, great. If I can make a card, wonderful. If I can play a card game with my kids, if they can come in bed with me and we can talk and do whatever, wonderful. If I can be in the living room with them doing stuff, great. It's finding that balance between, yes, I have this, I need to take care of it, but I have to live my life too. It can't be everything. That is how you, I don't want to say beat the depression. That's how I have depression. I come with it both genetically and circumstances. I mean, come on. So, and I'm an incredibly happy person, and I've been to hell and back. I mean, you heard my story. So I've been through a lot. And I wake up every morning very happy because I make the choice to be. My husband and I have been through a lot. We literally just celebrated our 21st anniversary on Friday.
So, Molly, we've got another question.
Absolutely.
This question is from Holly.
Hello, Holly. Beautiful name.
Hi. So I actually did research on Ehlers-Danlos Syndrome in undergrad, and we kind of related it to like a chronic pain, like treatment for chronic pain. And what is one thing I would say is it was really cool to listen to you talk, because I could see how it paralleled with the research that I did, like the stuff you said with the prevalence, the symptoms, and all that. But I was like, how did your physical therapist kind of keep you motivated to keep going? I know sometimes chronic pain patients, they have problems. They're like why? I don't want to do this today. Like, what's the point? Like, if I could have pain tomorrow, like, what are some ways that we can motivate you to want to keep going in PT?
Food has a lot to do with it. That doesn't mean be fake and be like, hey, how you doing? You know, it doesn't mean put on a show and be fake. But your mood, your excitement to see them that day, first talk to them about something that has nothing to do with their physical therapy. Something you've learned about them that they know and love. Maybe something, if they have a kid, talk to them, hey, how's Johnny? You know, how's this? Hey, I know you were reading a book last night. How's that? Anything that you know about their life, that something positive you can say, other than, hey, how are you? You know, and that's fine too. But talking to them other than just being your patient. That's why I say getting to know them is so crucial. Those first couple of appointments that you have with your EDSer is got to be about getting to know them almost more than getting to know their body, because you have to have that connection with them. You have to be able to know how they work. Like, and you know, if you ever meet my physical therapist, like if they ever come in and talk to you or anything like that, you know, they could tell you that I'm a very positive person. But I have my moments when I cry too. They both have seen me cry. Sometimes you need to get that out, and then you can go on. But the reason why those relationships work so well is because there was that connection there. We knew things about each other. I knew stuff about their families. I could say, hey, how are your kids doing? You know, my husband taught some of his kids, and they played baseball together, and I knew his wife was a teacher, and you know, so I could talk to him. It's finding something to talk about sometimes that has nothing to do with the health, nothing to do with the pain. And when you do have to talk about it, it's sometimes making it light, and sometimes, all right, we gotta do it, you know. But it's just keeping it where it's not heavy, where it's not. But if your patient comes into you one day, and you can tell by the way they're sitting, by their demeanor, their voice, they're already wrecked. Pull them into a room and let them go. Let them tell you what's up, because they've got to get it out to someone that gets some of it, you know, that is just going to listen to them, because they might not have any family member that believes them, that understands it. They might, you know, be dealing with having to leave their job. They might be dealing with, you know, a breakup because their partner doesn't want to deal with it anymore. You don't know. So it's okay if you've already formed that connection, you know, you don't want to jump in, hey, how's that relationship going? That's not what I mean. But it's okay to say, hey, you look like something's on your mind. Can I be here for you? Is there something you want to get off your chest? And if they say no, fine. You can then go on and do your business. But at least they know you care. You're asking, because they might not have anybody at home that's asking. Okay? It is all about that relationship and communication, 100%.
Thank you.
You're very welcome.
Well, people have a question. I might ask you one. So, before you got pregnant the first time, had a conversation with any physician about pregnancy and EDS?
Nope, made no connection to it whatsoever. Still, I mean, it wasn't on our radar. I mean, like I said, I was just avoiding things that hurt, being careful. It wasn't something, like for so long, it wasn't something that I even talked about with doctors. It wasn't something that I was having to go to the doctor every week for.
Okay.
There was nothing to do for it. That's why
Yeah.
I hear some people saying, oh, I was at the doctor's 3 times last week. I'm like, for what? Sometimes I don't know. And it might be because of their heart or their gastro or their this or that. I mean, it could be, you know, a whole bunch of stuff. I don't know. But if it's just because of So like musculoskeletal stuff, I'm like, what? For what? Sometimes I don't know what, and it might be in very good, necessary reasons. I'm not being judgmental about that, but I'm not at all. There's large spans of time when I don't go to a doctor unless I need to go to a doctor. But again, like I said, I'm on this side of this timeline. I've been doing this a long time. If it's people that are they're trying to get diagnosed, just got diagnosed, still trying to figure out why they can't digest food, why they bloat every time they eat, why they whatever the case may be, they're still trying to find all that out. They're going to be in the doctors a lot. So
Yeah. Anybody have any other questions? I'll ask another one. Molly, do you use anything regarding, and I don't know if you know this term, your proprioception or your awareness of your body and space?
yes, I'm a klutz.
Okay.
I bump
So
into the wall all the
hear that?
time.
Molly is a klutz.
I bump into walls all the time. My kids all the time. They're like, watch out for that doorway. It's ridiculous.
Right. So when a child is deemed clumsy,
Yes.
it could be due to poor proprioception,
Absolutely.
poor kinesthesia,
Yes.
and that could indicate that it's EDS.
It could.
May not be EDS. May not be EDS.
Correct. A big
But
thing.
when they run, if they look really awkward when they're running,
Yeah.
it could be.
If they're
Go ahead,
doing
Molly.
this thing,
Yeah.
if they have a lot of bruises, unfortunately, I hope it's not as much now. But in the past, we bruise a lot because of our skin and our blood vessels, but also because we're klutzes. And so we have a lot of bruises and scars and everything. So, a lot of kids with EDS would have bruises all over it, but if they weren't diagnosed with it, a lot of child abuse cases were brought up. So, yes, a lot of bruises, especially shins, knees, shoulder, bumping into the doorways. For some reason, doorways are really, I don't know why, they get you. I don't know.
If you see a child running and they don't have a normal arm swing,
Mm-hmm.
Molly did with her arms,
Yeah.
is typical.
That if their legs are not in that rhythm, they flail out some.
Right.
Definitely. A big thing. This was big thing. A lot. The core. Oh my gosh, your core. Everyone talks about your core. Your core. So crucial in your EDS patients is getting that strong core, especially making sure that their tushies are turning on, not turning on other people, but firing. The muscles are firing. They're turning on. I can lift my leg. Laying on my stomach, I can lift my leg up, but my muscle was not firing. It was not turning on. Richard got me on that one. So making sure that those muscle groups are actually turning on. We don't do it. I even have to make sure when I'm walking that my doctors get me. Bill Bales, my PT, my orthopedic surgeon will get me. He'll want to watch me walk down the hallway, and they get on me about my walk because they'll say I can't remember what they say now, but they make fun of me for the way I'm bringing up my leg or my foot, or that I'm not doing it right. I don't know, but I have issues because of my hips dislocating. I can't cross over that midline, and I have. I just have to be really careful because of subluxations and all that stuff. But yes, yeah. So with children, I would say a good place to look in kids. I'm not medically inclined to say this, but I think is their wrists, fingers, you know, is a good place to look. But really, if you go to grab a child's hand and you feel separation in their wrist, that elbow in their arms,
Yeah.
you know, that's.
Can I add to that, Molly? So let's say you're holding a child's hand, walking with them,
Yep.
and you sense that wrist.
You feel
just,
it. Yeah.
Yeah.
Definitely.
Yeah. Anybody have any last questions? Because I know it's now 8:22 because I'm looking at my phone and not my computer clock. Anybody have any last questions? Thank you all for attending. I hope you found this enlightening. And it's just so wonderful that, Molly, you're willing to share your story, because
Absolutely.
hearing from someone who is living it makes such a difference.
Oh, good.
It makes such a difference. Because, you know, you can read about things, you can do research on things, but it's not until you hear from someone
Right.
that it makes it real.
Yeah.
Because you're real. So thank you so much for your time tonight, and thank you, students and therapists, for taking time out of your busy schedule to join us tonight. So I put Molly's email in the chat, and she said you can email her with any questions. And I just put the Ehlers-Danlos.com website on there.
Fantastic resource.
Yes, it is, and it's got things you can print out. It's just a great resource. So, and I think I'll just repeat. Oh, look what Erin put in the chat, Molly. She said thank you, and then she put a zebra. One of the most important things you said tonight was that the therapists might be the ones that connect the dots.
Yes.
Listen, and might take that patient to finding the diagnosis. And even though you said, you know, what do you do with that diagnosis from then, at least it's been identified.
Yes. I mean, think about it. If we're going to PT, we're with you more than anybody else that we see. And you have that face-to-face, one-on-one time with us more than anybody else. And your personalities, I've found PT off and on for 30 years, and that time is more real and comfortable and important and valuable than any other time I've spent with someone in healthcare. So don't underestimate your value and importance. It really does mean the world to us when we find someone that we feel comfortable with. Oh, I said this to my husband last week, and I was like, oh my gosh, I hope I remember to say that. It just came into my head now. It's amazing anytime anyone feels comfortable enough to let someone else, a stranger essentially, get close enough to touch you. You know, we're coming to you vulnerable, scared, hurting, and we're coming to you and saying help. So the fact that we're letting you in, wanting you to come in and touch us. And a lot of people are afraid to be honest with you. I've had a hand doctor, she would not touch me because my thumb, they dislocate. She was scared to physically touch me. My surgeon that did my first hip surgery would not do it again because I'm a fail rate. Wouldn't do it again. A doctor up in New York, Hospital for Special Surgeries, would not do another hip surgery on me after my first one failed. He wouldn't do it. You know, they're scared. They don't want to be a fail rate. Don't be afraid of that. As long as you go slowly take your time, talk with us, spend that valuable time with us. You're going to have to pencil, however I don't know how your system works with scheduling, but if it can be extended for your EDS patients, like blocked, at 2 blocks of time instead of 1, however it works, do it, because that's how you're going to get answers for us, to be able to help. And that's all we're looking for, is just help. That's it. It's literally what I hear people say all the time. I just want help. I just want someone to listen to me. I just want help. I want someone to believe me. I hear that so much.
Validation.
Believe me. So,
Validation.
yes, exactly. Yep. So you can be the person that someone just needs to listen to them every once in a while. It's an invaluable relationship.
All right. So thank you, Molly. I really, really appreciate it, and hope we can keep contact.
Oh, yes.
Tell Richard I said hello.
I will. Yes. All right. Thank you, everybody. Thank you for inviting me. I'm really happy to be here. And please, if you have questions, email me. I'm more than happy to take the time to answer you.
Okay. You're getting lots of thank yous.
Oh, thank you. Oh.
Vera says, thank you for your bravery and for sharing your story so candidly.
Oh.
I know. Okay.
My pleasure. Oh, thank you. That was great. I have so much more.
I know.
I kept looking at the clock. I was like, oh gosh.
I know.